Good afternoon, everyone. Thank you, Corey, for inviting me to speak today. It's really a pleasure to come and speak at this event. So I'm going to talk about locally advanced non-small cell lung cancer and role of novel targeted agents in immunotherapy. And thank you, Corey, for the compliment. Now, if I can get just a little more sleep, I think I'll be all set. So this graph shows us overall and 5-year survival rates for all stages of non-small cell lung cancer. And as you will see, for stage 3A and 3B, even though the rates are slightly better than stage 4, they're still pretty dismal, opening up room for not only novel targeted agents, but perhaps immunotherapy. Locally advanced non-small cell lung cancer is quite heterogeneous in its presentation. It can vary from larger tumors with smaller lymph nodes or primarily central bulky tumors with mediastinal lymphadenopathy. And this poses certain challenges in terms of how this disease should be treated. We have a lot of options. Well, these patients can go on to surgery. Not so much N2 disease, but perhaps N1 disease can go on to approaches such as lobectomy and pneumonectomy. We can use chemotherapy in various forms, be it in the induction setting, adjuvant, or concurrent with radiation. And then radiation, as Dr. Simone will go on to detail further, can be given at certain different times as well as in the postoperative setting, so-called PORT. Even after surgical resection, you will notice that for stage 3A disease, where, quote unquote, the surgery has been done for curative intent, distant relapses remain a significant concern, with about 60% rate of distant relapse seen. Talking about unresectable non-small cell lung cancer or stage 3 patients, early in the 1990s, we saw a large trial that revealed concurrent chemoradiation or combination of radiation and chemotherapy was superior to radiation therapy alone. And this has been validated in several other studies that you will see in the graph on the right, noting pretty much the same theme, that concurrent chemoradiation is superior to sequential chemoradiation if the patients can otherwise tolerate that. A meta-analysis confirmed these findings. This was published a few years ago in the JCO. For both overall survival as well as progression-free survival, concurrent chemoradiation yielded superior results and has sort of become our standard to go to for unresectable locally advanced non-small cell lung cancer patients who otherwise have good pulmonary reserve, have good performance status, and are able to tolerate it. What about optimal choice of chemotherapy? Platinum-containing regimens with radiation are the standard approach. Early in the 80s and the 90s, cisplatin and vinblastine was the preferred approach. And since then, multiple combinations have been studied using drugs, older drugs like mitomycin, vindesin, more commonly used drugs like etoposide, paclitaxel, and more recently using drugs like pemetrexed, which I'll detail a little bit. This is a list of select concurrent chemoradiation trials in locally advanced non-small cell lung cancer. And as you can see, regardless of whichever chemotherapy combination is used, we usually are able to see a median survival in the range of 13 to 16 months, perhaps slightly higher, seen in a couple of phase 2 studies that utilized docetaxel as a consolidation arm. So which chemotherapy should we really use? This was a retrospective analysis conducted at the VA where the question was, is etoposide platinum better than carboplatin paclitaxel or vice versa? They analyzed results from 1,800 patients that were treated between 2001 and 2010. And what they found was that the overall survival for these patients treated with 2 different chemotherapy regimens was quite not different, with a hazard ratio of 0.97. What they did find was that etoposide and platinum was associated with increased morbidity, an increased rate of hospitalization, outpatient visit, infections, as well as things like acute kidney disease, which we would expect with the use of cisplatin. More recently, we saw results from the PROCLAIM study, which was designed to be a superiority trial to evaluate the use of pemetrexed and cisplatin concurrently with radiation therapy for unresectable patients with stage 3 disease. Well, the study took randomized patients to the investigator arm, which looked at cisplatin and pemetrexed in combination with thoracic radiation, compared with cisplatin and etoposide. And all these patients who had stable disease or better went on to consolidation therapy. The investigational arm received pemetrexed alone, and the control arm could receive investigator choice chemotherapy with either cisplatin etoposide, carboplatin paclitaxel, or cisnavalbine, depending on physician preference. As you will see, the graphs are probably hard to interpret, but it's pretty much easy to say that the overall survival and progression-free survival were not different in the two arms. The trial did not meet its primary endpoint for superiority with a hazard ratio of 0.98 for overall survival. The authors did find that pemetrexed and cisplatin had an overall favorable safety profile with less grade 3 to 4 adverse events compared to cisplatin and etoposide, was overall better tolerated, and they concluded that this could be used as an alternative with an overall acceptable safety profile. So what about consolidation chemotherapy? Should it really be used? Coming back to the same table that I talked to you about previously, this lists the most notable concurrent chemotherapy and radiation trials that have been conducted. 3 trials actually evaluated the use of consolidation chemotherapy. 2 phase 2 trials conducted by the SWOG 19 and 9504 looked at etoposide and platinum as well as docetaxel. 9504 actually yielded a significant improvement in median survival of 26 months, which further led to a phase 3 trial evaluating docetaxel as consolidation therapy versus placebo, which did not pan out in terms of favorable results for consolidation, leading to our current practice of not using it routinely. The LAMP, or the Locally Advanced Multimodality Protocol, utilized carboplatin and paclitaxel concurrently with radiation at weekly radiosensitizing doses, followed by consolidation carboplatin and paclitaxel in full chemotherapy doses, and yielded an overall survival of about 16 months. And this is one of the commonly used regimens currently. There has also been a pooled meta-analysis of consolidation chemotherapy. Is it really beneficial? So they looked at 41 studies, 7 of which were phase 3, and they took comparable data in terms of stage, performance status, histology, and median age. What they found out was that use of consolidation chemotherapy was really not associated with the statistical overall survival improvement. It was 19 months for patients that received consolidation versus 17.9 months who did not. And there was no difference in grade 3 to 5 toxicities. So in terms of choice of chemotherapy, our current standard is to use a platinum doublet. Cisplatin and etoposide is the preferred approach according to our NCCN and ASCO guidelines. If weekly carboplatin and paclitaxel is used, however, then 2 additional cycles of full-dose chemotherapy should be considered. And based on the PROCLAIM trial that was presented at ASCO last year, pemetrexed and cisplatin may be used as a healthy alternative, or as I want to say, as a safer alternative. Coming on to targeted agents in the multimodality setting, which is really going to be the bulk of this talk, I'm going to start off with an agent that's very familiar to all of us here, and that's cetuximab. Cetuximab is a potent radiation sensitizer and forms the backbone of treatment of many malignancies, including in combination with radiation in head and neck cancer. So naturally, it's been paired with radiation therapy in multiple trials for non-small cell lung cancer in the stage 3 setting. This table highlights some of the phase 2 trials that were conducted before a phase 3 trial was designed with cetuximab. And as you will see, this is a compendium of different radiation doses as well as different induction as well as concurrent chemotherapy backbones that were combined with cetuximab. Response rates varied from 22 to about 70% with these trials, leading the way for design of a larger phase 3 study. So RTOG 0617 was a large phase 3 trial that asked two questions. One question was, is a higher radiation dose really helpful for these patients with stage 3 disease? And secondly, adding cetuximab both in the concurrent as well as the consolidation setting, does that yield a higher overall survival, or does that actually yield a benefit? Overall, RTOG 0617 showed us that a higher dose of radiation at 74 gray was actually detrimental. That's the line on that's the Kaplan-Meier curve in blue with a hazard ratio of 1.45, and now we use 60 to 66 gray as our current standard for treatment of all these patients. Coming on to cetuximab, did cetuximab really make a difference? As you will see, the overall survival curve on the left and the progression-free survival curve on the right did not really denote an improvement with the use of cetuximab. In fact, patients that received cetuximab concurrently with chemotherapy and radiation had slightly higher rates of grade 3 to 5 toxicities on this trial. There was also no significant interaction in terms of EGFR expression. Perhaps patients that had high EGFR expression had slightly improved overall survival in the cetuximab subset, but could not be uniformly seen throughout the trial. Other EGFR agents, namely small tyrosine kinase inhibitors, erlotinib and gefitinib, have also been combined in combination with chemotherapy and radiation. And these are some small trials in the numbers of 15 to 50 patients that have been studied. However, the signal has not quite been that definitive or impressive to really warrant further studies. I will point out that this is quite not for unresectable patients, but there's a large NCI-led effort, the phase 3 Alchemist study, that's currently evaluating the role of targeted therapy in the multimodality setting. The Alchemist setting is evaluating patients with stage 1B, 2, and 3A non-small cell lung cancer after having undergone surgical resection as well as adjuvant chemotherapy, if indicated. All patients will receive centralized EGFR and ALK genotyping, and patients who have an EGFR mutation will receive erlotinib for 2 years. ALK rearranged non-small cell lung cancer will receive crizotinib, and patients that do not have a molecular alteration will actually go on to an arm to receive nivolumab or immunotherapy for 1 year. So this trial is currently ongoing and enrolling patients. How about immunotherapy in the multimodality setting? Dr. Langer briefly discussed the START trial in the pre-ARS questionnaire. And this was a large phase 3 trial evaluating tisagenlecleucel or LBLP25 vaccine, which is basically a vaccine targeting the MUC1 mucin glycoprotein. It is intended to stimulate a T-cell response with the use of this with the use of targeting MUC1. The trial intended to enroll about 1,600 patients with stage 3A and stage 3B non-small cell lung cancer who had undergone concurrent or sequential chemotherapy and radiation without disease progression following completion of such therapy. Patients were randomized in a 2:1 fashion to either receive the vaccine, which was given in an adjuvant fashion, first weekly for 8 weeks and then every 6 weeks thereafter, versus placebo. Overall, there was a slight numerical advantage in terms of overall survival to the vaccine at 25.6 versus 22.3 months. However, this was not statistically significant, leading us to assume that this was a negative trial. Subset analysis, however, did reveal something interesting. Patients that had received concurrent chemoradiation, which were a great majority, about 800 out of the 1,200 patients, actually saw an improvement in overall survival with a hazard ratio of 0.78, which you can visualize graphically better here. And in fact, there was a median overall survival improvement of 30.8 months versus 20.6 months. Granted, these are subset analyses. It is intriguing to see that patients that had undergone concurrent chemoradiation actually benefited from adjuvant vaccine. Moving on to other agents and immunotherapy agents, now it's becoming standard of care in our stage 4 setting to incorporate PD-1 agents either in the first line or second line setting. And there is a lot of interest, both biologically as well as from patients, to incorporate these agents into the stage 3 paradigm. So what is the rationale to do that? Well, there are several, and this has been borrowed from a publication from the Penn Group by Dr. Kalabasi. And allow me to walk you through this. This is the normal tumor microenvironment. There's a lot of anti-immune milieu that occurs within the tumor microenvironment, which can downregulate immune mechanisms and thus help to proliferate the tumor. Radiation can actually do various things. First of all, it can release antigens, which can then be expressed. It can also upregulate PD-L1 as well as CTLA-4 expression. It can also lead to release of cytokines, which can all induce an immune response and therefore effectively combine and synergize with immunotherapy, either PD-1 approaches or CTLA-4 approaches. Not only that, as we've seen in the RADVAX model, and this is from a melanoma patient that was treated with CTLA-4 approach, we have seen that radiation followed by immunotherapy can actually lead to shrinkage of tumors at sites where radiation has not even been given. For this patient at baseline, this part of this tumor was irradiated, followed by receipt of anti-CTLA-4 therapy, and we actually saw shrinkage in non-irradiated tumor sites as well. So there's a lot of biologic rationale to combine these therapies and a lot of interest nationally to use these agents. This is a list of some ongoing trials incorporating PD-1 as well as PD-L1 agents along with radiation therapy. The top 2 trials are primarily looking at safety and maximum tolerated dose, and these trials are looking at nivolumab and pembrolizumab given concurrently. Small trials which are currently ongoing. Pembrolizumab is also being evaluated in the consolidation setting with the goal of time to distant relapse, which was recently suspended, not entirely sure of the reasons just yet. Atezolizumab is another PD-1 agent that's being evaluated, and again, in a safety setting. It has 2 arms which are looking at both concurrent as well as consolidation in combination with carboplatin and paclitaxel. Durvalumab is being evaluated in the largest of these trials. It's a phase 3 trial with an N of 700 patients in which durvalumab is being used in the consolidation setting, not really in the concurrent setting yet, and it's ongoing, its accrual. START-2 was a follow-up trial to START-1 using tesemitide in patients specifically having received concurrent chemoradiation. This has recently been terminated. Tesemitide is also being evaluated in combination with bevacizumab, and this trial is being run out of ECOG, and it's currently recruiting. So in conclusion, concurrent chemoradiation with platinum-based chemotherapy provides a survival benefit for patients with stage 3 non-small cell lung cancer compared to sequential chemotherapy followed by radiation or radiation therapy alone. Current evidence supports the use of cisplatin and etoposide at regular systemic doses or weekly regimen of carboplatin and paclitaxel. There is no benefit of radiation dose escalation as seen on the RTOG trial, and newer agents are currently being developed with encouraging preliminary results, and I'm sure we'll be incorporating these into the use of our paradigm in the multimodality setting. Thank you.